All right, so the point of these member meetups are just spend some time engaging in some discussion. This started as a result of, I believe it was Sarah and I were talking, and I was like, hey, I'd love to do something, Patreon talk with you and the Daily BAers, the support on there. And then we've hit On Location so hard. I was like, the rule is we cannot talk about anything that we've done there. Like, that is all we've been talking about. And she's like, what about the ethics of reopening and something around reopening? And let's hit up David Cox. And so that's how this all started. Maybe we can do just a quick introduction for the two of you. And then for an agenda, we don't have anything really planned. We can run this as a bit of a Q&A, a group discussion. Everyone's welcome to get involved. I know David for sure and Sarah have some points they wanted to make or things that we can start talking about. But just full disclosure for you two, I didn't plan anything outside of showing up and getting rolling on this. I've got some thoughts, but and I can get us rolling. But yeah, let's start with Sarah.
Hi.
Say what's up.
Hello. Thanks for joining us. I'm really excited to talk to everybody today. I'm about a third of the way through my afternoon cup of coffee, so I anticipate that I will become a more fluent speaker with more increased caffeine intake. So give me a couple minutes. I'm Ryan's partner with Team On Location. I'm a behavior analyst. I've been in this field for like 20 years. I've been certified. I think this is going to be like 16 years this summer, which in behavior analysis, since more than 50% of our current certificates have been certified for less than 5 years, makes me like a grandma in behavior analytics times. I'm a grandma. And I'm totally comfortable with that. Like I've shared earlier, I do laundry, like Ryan's laundry when he stays in my house. I've been making a lot of beds. I've been feeding a lot of kids. And I've like really just like softened. I made a cake this morning. It's my daughter's 14th corn birthday. And so that's what I've been doing today. I ran an ABA business for 15 years. I just exited last June and I loved every minute of it almost. And I've been, really closely monitoring everything that's been going on with COVID-19 from the perspective of the work that I do with the California Association for Behavior Analysis. I'm the past president of CalABA, but right now I work as a development consultant. And, we've had a lot of legislative changes made here in California. And we thankfully have Michelle Hyde on this Zoom, who is the public policy chair for CalABA. So I'm counting on her to really kind of talk about how the intersection of legislation and ethics as it relates to service provision for essential health workers, like all of us have been categorized. I don't know if any of you guys have attended any of the Coachella talks or some of the webinars that we've been doing CalABA. We've been trying to do a really nice job of providing information for our member community, but also for the broader behavior analytic community during this time. And that's something that I've noticed has been happening across the board, is really a vast sharing of resources and really open resources. And I believe that that's really important. And I hope that that persists in a post-COVID environment. And David Cox, I've known, oh my gosh, since you were just like a wee little behavior analyst in Denver, Colorado. I mean, so what, like a decade maybe?
Your grandma's showing again.
I want to say that you interviewed me the day I think I passed the test.
I think, yeah. And we went to Tag yeah, which is a really fun restaurant in downtown Denver. And so David used to work for me. And I have just been, tremendously proud of the contributions that he has made and continues to make in our community. And I really think a lot of the work that David, Matt Broadhead, and Sean Quigley have done in the ethics space around behavior analysis is just so important. And so when Ryan and I were talking about this, I was like, I have things to say, but if you really want to talk to someone that has a deep and vast knowledge of ethics, then David's our guy. Plus, I just like to see him as much as possible. So any chance I can get to rope him in so we can spend some QT on Zoom, I'm going to do it. I think I have, I have 2 kids. I have 2 bonus kids. I have an elderly beagle, and I live in the Bay Area. So we've been sheltering in place for over 2 months now. We're going on 2 months and 1 week. And this coffee is spiked with Kahlua. And that's what I have.
All right.
Oh,
full disclosure. All right, Dave, you got a lot to live up to here.
Yeah, I don't know how I'm going to beat that. It's so boring. So I'm David. I'm happy to meet you all and chat with you today. I think it's going to be a really fun conversation. So I got started in behavior analysis back in 2006, what would now be called an RBT, though we didn't call it that back then. Worked in autism DD, until about 2014, up as a BCBA. And then I got more into research, went back to get my PhD, and there I shifted more to experimental analysis of behavior and behavioral health more broadly, I suppose. So physical activity, substance abuse, things like that. And then after that, I did a postdoc at Johns Hopkins where I started to get really into machine learning and big data and how we might be able to bring some of that stuff into behavior analysis. And along that whole route, I've been fascinated with ethics. Got a master's in bioethics along the way. And I think there's a lot of interaction between behavior analysis and ethics that leads to exciting conversations and opportunities for the future. Currently live in Florida. I'm a principal analyst at GuideWell. So we provide a bunch of different services. My role is primarily as a researcher, where we're trying to take behavioral interventions that we know are effective with adults and scale them up to kind of population level health, primarily using like big data techniques and machine learning stuff. I also have 2 dogs. They're geriatric, sleeping probably around here somewhere. I finished my last cup of coffee about an hour ago, so I might tail off towards the end of the conversation. I just hear it's coming up, but yeah.
We'll just like even each other out.
Yeah, it'll be great.
So where do we want to start here? Maybe, David, you've been reading a ton and contributing into this discussion in the behavior analysis and practice, like rapid publication articles. So maybe you can start with just giving us a little overview of maybe just a little bit about what's been published in there and what's going on. And then maybe we'll transition into like, what does this mean for reopening?
Yeah, I think that's great. And it's been fun to follow the dialogue. I think there are kind of 2 big things, or two observations that I think are helpful in kind of framing the conversation, the discussion. The first was we went through this really interesting initial stage where all of a sudden it was COVID's a thing, and there were a lot of kind of acute responses. How do we kind of stabilize where we're at and make a decision now to just keep people safe? We're now kind of on the back end of that, shifting into this recognition that we're in kind of a long-term maintenance phase right now. And I think that's where this conversation about reopening becomes really important, because we're recognizing we can't stay where we're at now forever. There are a lot of ethical concerns with that, economic concerns and things like that. So that's where this conversation of how do we shift to this long-term maintenance of the current situation while we wait for a vaccine, essentially. The other thing, so that's kind of one observation, and why I think this conversation is actually really timely, because Georgia just opened up, and I think a lot of people are thinking about these things. The second observation, which I think gets more at the heart of why these conversations have been so difficult, is that we're within a Western ethical framework, which is really what has shaped medical ethics, which then shaped psychological and behavior analytic frameworks of ethics. We kind of had this nice hierarchy of client comes first. After that, it's like their immediate family caregivers. After that, we should be thinking about the profession and maybe our colleagues at our business. And then after that, the larger society is important but comes last, definitely ranked lowest. And nobody has really questioned this. We haven't really had a reason to challenge that ranking. And then COVID hit. And I think what's been interesting about that is within the medical ethics and clinical ethics communities, the client still comes first without a doubt, because that's who our duty is to provide care to. But now we're in this weird thing where it's unclear what comes second. You know, some people have argued that public health should come second. That should be our next concern. So definitely client, but after that, we have to think about the larger community as we operate. Others say, no, it's not necessarily public health, but it's the family and caregiver that should be kind of second. That's the next ranking. So other people say, well, we have to think about the profession long-term. That should be second after the client and make decisions regarding that. And I think it's that dialogue, this kind of shifting of our hierarchy of values that's led to a lot of really interesting dialogue. And we haven't settled on any answer. We don't know what's right yet. So those, I guess, my 2 observations that I'll kick it off with. And I don't know if people have thoughts, or if Sarah has something she wants to follow.
Yeah, I read one of the articles that you sent to me from the Hastings Center, and I think that they really did a nice job of kind of conceptualizing how we can think about this in a very succinct way. And what they said was this, is that reopening is not simply science or politics, because I think right now that's what we're seeing a lot in the media is this is a partisan issue. If you're a red state, then you're reopening and you're not going to wear a mask. And if you're, a blue state, then you're wearing a mask and, everything's shut down. And it's also not just about science, because there's things that we understand, there's things that we don't understand. This is also a values conversation. Because, to your point, David, we clearly understand at this point that there are catastrophic effects that happen to people as a result of closing down or lockdown or quarantine, whatever verbiage you want to use, right? And this disproportionately affects poor people, it disproportionately affects people of low SES, of people of color. We even see in terms of the mortality rates of COVID-19, this has disproportionately affected Latino and African-American communities. So we know that there's a lot of bad stuff that's happens there. We also know that there's a lot of catastrophic effects of opening, which is most likely going to be realized in the form of overload in the healthcare system and death. And so what I liked about this article is it framed this in terms of like, this is an issue about medicine, epidemiology, or economics, that this is a question about the fair distribution of benefits and burdens. And so it's really like, what do we value? How do we distribute those benefits and burdens across the population? How do we make those decisions? And I think that that's part of what I think has been missing in some of the media that I see is it's like, oh, like you either, like I live in California. So Gavin Newsom's like, hey, we're going to, here is our criterion for reopening. And it's, being able to have rapid testing, contact tracing, reduce the burden to, healthcare, keep the, new cases at a minimum. But we still acknowledge that even in spite of all of those things, more people are going to die. And so like, how do we wrap our heads around and kind of conceptualize and think about as a community, what are we willing to allow, so to speak? What are we willing to not allow? And that's where I think the conversation needs to happen more. And I haven't seen that as much in mainstream media.
Yeah, I would agree. And in hearing you talk too, I'm reminded of sometimes perhaps tongue-in-cheek critiques of a lot of American ethics literature, and that we do like to make it black and white. This is right, this is wrong. Whereas some other countries take a very much more gray approach. They know it's complex, it's messy, that the right answer isn't the same for everybody even.
Well, I think as behavior analysts, sometimes this is really hard because we tend to be a very rule governed field, right? We're like, okay, I was told I can do this, I can't do this. This is the procedure for this. This is not the procedure for this is the SD, this is the S delta. And this is something where it's like, oh my gosh, there's so much gray area. And I think the one thing that has come up over and over again is there is no such thing as one size fits all when it comes to anything that we're doing, but specifically when it comes to how we go about serving our clients, because so much of this is going to be determined by, a lot of really unique variables. Not the least of which is, the city or county or state that you reside in and whatever the guidelines are in that area, but also looking at the vulnerabilities of the populations you serve, the age of the populations you serve, the staff that you have working for you. It's so complex. And so that's why I've been really heartened to see so much literature and articles coming out in our field to really, especially with the behavior analyst in practice, kind of COVID-19 special edition. And David, I think, do you have 2 articles now that have been published in that?
I do, yeah.
So we can, understand that again, it's not just science. It's not politics either. It's the science and the values piece. And then again, how do we, have those discussions? What are frameworks that we can reference? And I think just having a fundamental understanding of what has been kind of the Western medical ethical perspective to date, and then how can we kind of realign that given the current context of the environment that we're in right now?
So is there an answer to that how showing up yet? That's, I think, the thing that everyone's eager for, or if we're figuring out on our own, I think people like to hear the perspective of others that are also making decisions and trying to move forward here, right?
Do you mean is there an answer to how we go about realigning that structure of values?
Yeah, and how do we start making these decisions? If you're, the TA hasn't been built yet, right?
Yeah. It's interesting. There's a good article, I think it was in that laundry list of links I sent you all. There was a conversation with 5 ethicists or something like that. I don't remember the website. I think it was.
No
Well, I'm going to
worries.
bring it up because I have everything bookmarked because I was like,
Oh,
David,
yeah.
I don't
Yeah,
have time to
share
look
that
at
link.
all of these.
What I love about that conversation, so these are a conversation with 5 prominent ethicists from the United States and their responses to a bunch of questions about reopening, what these things look like. And what I love about it is the diversity of opinion that pops up that kind of falls along that continuum of some people say like, no, we really need to be thinking about public health primarily. Others say like, no, we really need to be focusing on vulnerable populations. And really addressing poverty and some of these other issues that already play a big role in health generally and are going to be exacerbated as if the economic hardships continue, and other people take other perspectives. Point being, I don't know that there's like a stamp of this is what's right to do. But the one thing that seems to be emerging in a lot of the conversations, it's kind of what Sarah had said in that everybody's situation and context is a little bit different. The population I serve, the staff I have, the size of my organization, where I'm located with state, regional, federal laws, that it seems like most people agree that it is at that organizational level that these decisions will have to be made. So like the field of behavior analysis probably wouldn't want to come out and say, this is how everyone should do it. Or even a state agency to say like, this is how everyone should do it. Because everybody's situation is going to be so unique. So what I'm doing is subverting and answering your question.
No, that's good. And I think that's part of it is we're used to just, I would say a large degree in our field, things kind of being dictated by some entity or SME group and such. And is it safe to say that like this decision doesn't seem that it's going to come from those traditional routes? Like it is in the organization rather than an ABI, a BACB, right?
I think so. I mean, I'll preface this next comment with the fact that I'm highly biased in this regard. So one of those papers that's coming out in the special issue on COVID is a guide for establishing ethics committees for behavioral health organizations. So for a long time, I've really viewed that the guidelines for professional conduct are fantastic guidelines for ethical decision making. But when you really take these generally written rules and try to apply them to specific instances, that becomes really tricky to try to police an entire field or even globally until 2022 or whenever. And so for a while, I've been a proponent, I suppose, of this, getting down at that organizational level, creating systems and processes for making these ethical decisions based on the unique situations people face. So I'm a proponent of that view, but again, I'm biased in that regard, and I know others.
That's really cool. I could see one way for us going is to maybe try to work through some hypothetical scenarios or something here. Might be useful. Did you have anything else, Sarah?
Oh, no, I was just saying, I just linked the article David was referring to was from the New York Times Magazine. And so I just put it up in the chat for you guys to look at.
Cool, sweet.
Yeah.
Does anyone have any questions at this point or thoughts? All right, Christine's got something.
Hi guys. Okay. I think everyone here is trying to figure out how to reopen right now. And I literally just reopened my center last week. And we're located in Las Vegas. We're a startup company. We're really new. We literally opened our doors, I want to say October, got credentialed with everybody by January, and then had to close in March. So I'm the clinical director right now. And right now what I did in order to reopen and get our doors kind of sort of back open was I limited sessions. So I did one client in the center with one RBT, and that one RBT worked with that client for the 5 days or however many hours it was. And then we would close down for 30 minutes, and then another client would come after we were able to sanitize and whatnot going forward. And we did this for, I think we had 6 clients that decided they wanted to come back. So next week, we're going to actually expand those services, since it's been going well for the past 2 weeks, to allow 2 to 3 clients in the center at one time. With all of this said, my main concern is more of the logistics of how to make sure that the wording of my staff, you know, that they're safe and that we're doing everything ethical and addressing all of the client concerns, parent concerns. And like, I had a parent ask me, does my child have to wear a mask during their session? Like, no, they don't, but we're going to take, extra precautions with hand washing procedures. Anytime they touch their face, cough, sneeze, they're going to have to wash their hands. Same thing with the staff. And they're going to be in their little rooms and they're not going to be able to have social interaction. And the whole point of having session in a clinic is for that social aspect and to get those peer relationships with other clients in the center. But since we're doing it this way and limiting the social interaction and still maintaining social distance, it puts me in a situation where I'm like, okay, do we keep doing this, or how do we add that social component? And what does that social component look like now, given that we're supposed to, maintain 6 feet distance? Since when we're trying to teach our clients before to give high fives or hugs or whatever it was that we were teaching before.
Yeah, and I think you're kind of talking about two different things. I think you're talking about kind of the ethics of what we're doing, but I also think this is like some operational issues of how to do this. And there's definitely like Julie Cornack, for example, is lead author of another article that just got published from the behavior in BAP in terms of like, here's how to kind of reopen some of your clinics. I haven't had a chance to review everything. But I also had a call yesterday with Tammy Keating, who is the quality assurance officer for Canadian Behavioral Health, and she spent 25 years in quality assurance at Kaiser, and so they've been really kind of looking at the nuts and bolts of how to, like, the operational aspects of how you do this, and so I'll address that just kind of really briefly, because I think in this conversation there's no way for us to not address that. Because from my perspective, doing this in an ethical way also means ensuring that your operations and systems are, aligned with your values as a company and what you've said that you guys are going to prioritize. Because the bottom line here is there's no way for you to alleviate all risk. That can't happen. That's not going to happen. And so I think it's really important for any ABA organization to understand that if you are seeing clients in person, there is risk involved, and that is just a truth. But there is ways to try to minimize this risk. But I also think from the business perspective, and something that you guys are going to have to be really, really careful about monitoring over the next year or so until we are not operating in these conditions. What's happening right now at a federal level, at a state level, is an issue of like who's responsible for what and who's liable for what. So for example, in California, for example, and this has happened in numerous other states, like Illinois, I know also has the same law. It just was determined that all workers' comp claims, if you are diagnosed with coronavirus, it's going to be presumptive that you have, this was something that you obtained at work. So you will be allowed to file a workers' comp claim. This is not supposed to affect business owners' experience modification, which you guys know is the primary metric used for establishing the rates that you pay in workers' comp. But there's going to be a presumptive assumption that this is something that you got from work. And this is something, again, that I think 8 or 9 states have already passed. There's also issues right now in terms of, are you guys going to be able to obtain any relief using your business interruption policy with your insurance? And all, insurance carriers and like across the United States are like, no, communicable diseases are accepted from this. We're not doing this. And part of this is because the federal government and state, governments are trying to cost shift. Because what we also see happening in the intersection of all of this is all of these emergency packages that have been passed out at federal and state level, all of the unemployment benefits that are being offered. What they're doing is decimating budgets. And then for city budgets right now, like, I don't know if you guys know this, like for the city of Oakland and the city of San Francisco, do you know what their #1 revenue generator is? It's very funny. And this is true for many cities. Parking tickets. Oh,
fascinating.
But there's no parking tickets being issued right now because there's no one deployed in the field right now because there's no contact. And so you have municipalities that are looking at, tax revenue, parking tickets, and other revenue generators that have now bottomed out on all of this. And I'm just sharing all of these things to just kind of provide some context for how complex all of this is. And to kind of go back to what you were asking about earlier, Christine, I think, if it was me, I don't believe that I would be willing to create what I believe would be an unnecessary risk by thinking about how do we socialize children in a clinic setting at this point, because I think that is, for me, that would be like a hard stop on, on safety. I think, it's really important to make sure that you have families signing waivers that are coming into your center. I assume that you're doing that you have staff signing waivers that are continuing to.
Has waivers.
Okay, great. That you're online. What?
That was the first thing I did.
Awesome. And I also think, and obviously I think for all of us, we are fine if parents are like, hey, I don't feel comfortable doing that. We're like, great, let's see if we can pivot to telehealth. And also if we have staff that are like, I feel really uncomfortable doing this because I have people in my home that are a vulnerable population. I am, immunocompromised, et cetera. But I think again, it's about mitigating risk. And I appreciate that there really are, some children that definitely need to be getting back into face-to-face services, because without these services, there could be very dire, medical, psychological consequences. But if that was me, I wouldn't push that envelope right now in terms of trying to create some type of like social opportunity, because I think it's just very, very challenging to control. And again, if we're looking at mitigating risk, I try to mitigate it as much as possible, but I would look at that. I think that that's added risk that's unnecessary at this point. And that's my personal opinion.
I have a follow-up question to that, because you mentioned essential or like mitigating. So what do we do with clients who have families that are essential workers, that are doctors, nurses, grocery store workers? Like, I want to provide services, but how do I provide those services safely to those clients if their family members are exposed to the virus? Like, I don't want to discriminate against them because of their family's work. I don't feel that's ethical. But at the same time, their insurance or their funding sources don't cover telehealth services for 97153 and only allow 97156, or whatever it is. So.
Mm-hmm. I've thought about it, but I don't need to be the only one talking. I don't know, David, if you want to tackle that first, and then I can about how I feel.
Yeah, no, I mean, I think, and I'll throw out a second recommendation to that Cornack article. I think it's really nice. And I think actually within that, they talk a little bit about setting up teams of provider-client relationships, staff-client relationships, which is also echoes some of the checklist stuff that the American Medical Association put out in terms of making a plan, opening incrementally, ensuring safety of patients through these like social grouping systems and things like that. And so I think that same kind of approach could be taken if you had staff that felt comfortable going in the home or something like that and providing services in a highly risky situation, and knowing that you were going to keep that staff and that client isolated from others that didn't sign up to have that person next to them, or within social distancing guidelines, or I should say physical distancing, because it's not social distancing. Yeah. So those are my, I guess, kind of first thoughts on Sarah's.
I think the hard thing about all of this is this also is this is an unprecedented time where we are reliant on the behavior of other people, of which sometimes we can verify and sometimes we can't, right? I mean, so if you think about it from like a kind of virus spread issue. So let's say you're serving that essential healthcare worker's child who deserves services, and that essential healthcare worker is going into a hospital which actually just ran out of appropriate PPE. So this person has been inadvertently exposed, even though it wasn't their choice, but where they worked didn't take care of them. And so they might be inadvertently exposed. And so then do you know what I mean? Like, this is just, I mean, it's so challenging. And I think David always says this, and I agree. It's like, there's no like supremely right answers. It's just this entirely gray area to navigate. But I also think something that I've heard a lot in behavior analysis during the context of this pandemic is, especially for those of us that work in behavioral health, and not everyone in behavior analysis does. A lot of people in behavior analysis are focused on providing services in education settings, in community settings. But for those of us that are really using a medical model, we have an obligation to make sure that we are treating our patients just like healthcare professionals have an obligation to treat patients. But I think, and this is where I'm interested in David's thoughts, but to what end, right? I mean, you've seen different kind of groups like nurses associations, doctors groups say, hey, we want to treat our patients, but if you don't provide us with the appropriate medical equipment, you're putting us at risk, you're putting our children at risk, you're putting our families at risk. And then where is the intersection of what, like, am I not important? Do I not matter? And are you saying that people that I'm treating matter more than me? And so therefore I should put my life at risk? Because especially as we're continuing to look at the mortality rates, and we see a very high mortality rate, obviously, of, older people with that are immunocompromised, but then also healthcare workers. And I think I'm still trying to like figure out how do we best navigate that piece. And I don't know, David, if you have like kind of gems of wisdom, but this is, again, like, this is just such a complex.
Oh, it's so hard.
So complex.
I don't know that I have gems of wisdom, but I have observations from ethics chatter around the country. So I think one thing that's really interesting that you hit on, so traditionally in healthcare ethics, there has been a focus on client and public health. That's what we're trying to manage, essentially. Within this COVID epidemic, the importance of the healthcare workers and employees has popped up, as they're just as important as our obligations to the clients and public health, mainly because they're valuable in and of themselves because they're people. But also, if they get sick and die, then there's nobody to help out any of the clients anyway. So I think that's an observation that's popped up, that our healthcare workers, including our staffs and employees, are just as important as clients in the public health. The other interesting thing that's popped up within this conversation, which speaks to this reopening conversation, is most people agree that we should be opening in waves of sectors. So we shouldn't be opening up like regions of the country or regions of locations geographically, but certain sectors. And most people agree that that first sector that we need to make sure is stable before we start expanding out are those essential workers and the healthcare staff. So are they being taken care of? Is the probability that they're going to get sick and reduce the overall healthcare workforce is that stable or increasing, that we have support for them? And once that's good to go, then expanding outward. So those are just kind of two random observations. Another, I guess, kind of related observation that gets back to this providing services for clients of, say, a physician or a nurse or something like that. There's been a lot of pushes in a bunch of medical communities to really speak to that idea of protecting the family of healthcare workers. So early on, there were people that were working, 20-hour shifts, maybe a couple days straight, going home and laying in bed in the house with their family and kids. Since then, there have been a lot of support pieces put in place around the country to give healthcare workers a place to sleep or alternative lodging so they don't have to be near their family, or ways to, as best they can, sanitize themselves or whatnot before they come into contact with their family. So one thing that I would be curious about if I have a bunch of clients whose parents are physicians or nurses is I'd ask them about those things. Like, is their hospital doing that stuff? Because it's possible that there's a reduced risk for those caregiver or for those clients in recent weeks or months, because this has been a novel addition, I guess, to that conversation.
Yeah, I don't actually know that we're answering any of your questions, Christine. I think, in fact, we're just bringing up new other questions, and they're able to consider.
It's fine. I mean, this is the whole point of the discussion, is to just get the ball rolling and talking. And I just want to know what other agencies also are doing in their process of reopening or restarting services for some of their clients.
I think when I was talking to Tammy Keating yesterday with Katie, what she was working on is kind of creating a decision-making grid for them, and looking at what are, like, for example, like in California, we have 4 different phases. Where I live, we're in phase 1, and we're kind of like inching into phase 2. There are specific benchmarks to be able to go into these phases, and then these phases are segmented by county right now, but municipalities are allowed to, that have more stricter measures, supersede the state phases, and then, more rural counties can ask for exceptions to be put further down the phasing. So there's a lot of complexity. And that's one of the things, that's been, I think, really challenging for all of us. And again, this is my opinion. There's been a real lack of cohesive federal response. And so this has been largely punted to states, and like what happens where you live is also largely being governed by whether you have a Democratic or Republican governor, or Democratic or Republican mayor even. So even in California, Gavin Newsom is a Democratic governor, but like in some places, like in the Central Valley, there's Republican mayors, and they're saying like, we refuse to do this because you're killing our economy. And there you go.
In Vegas, one of our mayors wanted to, make us tribute as a control group. So that was
yeah, I watched that CNN interview with Anderson Cooper.
Yeah. So that was awesome,
But again, to kind of go back to the whole grid idea, so I think it's really part of this is like looking at where you operate in the context of whoever's rules you have to follow the most. And so I think looking at those things is really important. And I think also looking at, and managing, okay, is the data that's coming out of my like city, county, or state, whatever one that you are looking at in terms of your own individual practice, are we being able to maintain a low rate of cases? Are we being able to bring this R0 lower? Are we overwhelming our healthcare system? And those markers and how that data moves up or down is largely going to affect, what you will be able to either continue to maybe expand on or what you might have to contract. So I think there's that piece too. I think also a big part of this, and so in California, for example, something that's happening is it actually, and of course, California, we're doing this, there's some competing contingencies for employees in terms of returning to work, because some employees in California can actually earn more money staying on unemployment versus going back to work. And then also, again, like looking at the risk they might be taking. And so from, a perspective potentially of maybe like a RBT, like you're asking me to go into this situation where I'm potentially being, exposed to a greater risk of contracting COVID-19, or the other contingent, or I can just stay home, earn more money, and not have that risk. Like, this is going to, to me, this is not a challenging decision for a lot of people. And so I think there's also, looking at how agencies are operating is also kind of understanding your workforce and like, what are, people open, to do, surveying people, like, do you identify as a vulnerable population? Do you have people in your house that are a vulnerable population? And then I think a lot of this is also going to come down to the willingness of families, that, if you can do telehealth, obviously that's optimal, right? Like, then no one has to come in contact with anybody. Great. But that's not an answer to everything, right? I think we've looked at telehealth as this like panacea and magical thing. And I think there's some great things about it, but we all know that there are some limitations, and there are clients for which in-person services are, critical importance, and really trying to get them back to that is really important. So we don't see regression or potential other, really catastrophic effects. And so like kind of from Kitty Ann's perspective, what I gathered from my conversation with Tammy is like, there's a lot of things that need to be evaluated. These things need to be evaluated like literally continually. And I think what most organizations will say has been the most important thing is constant communication of what are we doing? This might shift on a daily basis. If it's going to shift, why is it going to shift? How are we going to make decisions? And just being open, transparent, and constantly communicating. And I don't know, especially Stephen, I'm interested to kind of see what you guys have done at CBA. But I think the name of the game here is like, don't be afraid to over communicate, and don't be afraid to say like, hey, what we thought was a good decision yesterday, today is not the best decision. Here's why. So we're going to change. And like, that's where we're at. And that's okay. I don't think people in any way, shape, or form need to hold themselves to a policy that you made in March that made sense based on the science, evidence, et cetera, that we had at that time, when there's constantly new information coming out. And so again, that communication and willingness to continue to be pivot and nimble, and really let, data and also this overlay kind of values and ethics of your organization guide decision-making, to me is paramount.
Yeah. And I think I've been prefacing all of my emails to my staff, like, we're still in a very fluid situation, and I just really need you guys to be flexible, and I thank you guys for your patience and understanding. And, there's just so much one person can say to them to, take that worry and uncertainty away from them.
Yeah, Stephen, I want to know what you guys are doing. I'm putting you on the spot. Hi, I miss you also.
All of you, of course. So at CBA, we're in Kentucky. We provide services throughout the state, provide community-based services, and we have two clinics. Two clinics. So all of our community-based services were moved to telehealth. So that continues. That has not changed. We are not in person with anybody. There are other company. It's a state mandate from our division of behavioral health that said no in-person services. There are companies out there that are not following that, of course. Imagine that. But we've gone completely telehealth with our community services. Our center-based services, very similar to what I'm hearing, is we, back in mid-March. I mean, it seems like 10 years ago. But back in mid-March, you shut down all services, shut down everything in person, of course, all in clinic. We slowly transitioned to telehealth with our behavior analysts. Again, trying to navigate those waters. Our community-based services and our clinic-based services, different funders, different way of doing things, as you guys all know. Fast forward to the last few weeks. This is now the second week. We've started a very slow opening of our clinic. Same thing, one-on-one, small contained rooms. We, Ryan, you and Megan, who have been to our center, we have a big open space, a big motor room. We bought dividers and things are completely separate. So everyone has an individual room. Most kids are half day. We're transitioning to try a full day. Staff are also half day. And we have the deep clean time in between for all the outgoing staff to go on. We do, again, as everything else, temperature checks, symptom checks on both staff, individuals, even talking with parents. And so this is now our, like I said, our second week of now 5 days a week of service. And each day is different. As you know, each day is a new adventure. Our executive program director, Sharon, who some of you know, poor Sharon, every morning when we do the temperature checks or we do the symptom checks, if a staff says I have an upset stomach, we have a team of people to make the decision whether or not that person goes into work or not. And Sharon gets those initial calls. So we're being extremely overly cautious for a reason, because it's what we have to do. So we're continuing to slowly transition. We've also been fortunate that in one of our centers that we had an empty space next door, and the landlord that owns our building is renting that space to us very cheap because she wants kids to get services. And so we've been able to bring back more kids with more staff. Luckily, we applied for the PPP and we received that, and so we have not had to lay off and terminate anybody as of yet. Like I said, we're still slowly trying to move through the process, but each and every one of you have so far. Every day is different. Every hour is different on what we do with our next step. Those that we have not brought back, we are communicating with as much as we can. We have standing meetings, some trainings, everything that we can to just make sure that they're constantly in the loop. Weekly webinars with our staff members that on telehealth skills. We give them plenty of resources. Again, try to stay in communication. Trivia things, happy hours, anything we can to try and just stay in contact, especially with our community staff who were already not in an office and already not people that were connected, even more so feel disconnected during this time. And of course, as you imagine, we've got folks that were used to full hours, full paychecks, all that prior to, and now still trying to come to realization. And I'd love to hear from everybody. And this is the absolute biggest question that and I've talked to as many people as I can, is how to motivate staff and how to really make the staff realize that this is not something that's temporary. But this is something that is continuing on, especially with our telehealth. Our state has been very clear on that telehealth is here for quite a long time, and that our population is the last to even be allowed to even be in the homes. So we've of course taken quite the hit, but again, every day just trying to get through what we can. Our goal is always to stay one day ahead.
Yeah.
Most days.
I think it's a reasonable expectation.
Mm.
Also hard to do, but reasonable.
Very hard to do.
Oh yeah.
We have a really great team.
So yeah, I don't know. I somewhat keep in touch with Jason. What's his role there? CEO officially?
CEO, president, owner.
Yeah, we usually text back and forth, I don't know, once a week, once every 2 weeks. And I know that he's been up all hours of the day, constantly going through all this PPP and how to go about that. It sounds like, I guess what I'm getting at is, I think Stephen talks about some really cool things on the clinical side, like what they're doing, but also that team I know is just like working the management team to the bone, trying to figure out how to even keep that day ahead. And I've talked with Jason a little bit about just how hellacious that is on the hours he's putting in, just reading, getting knowledgeable, figuring out what to do, because everything's changing so fast.
Yes. And everyone's playing multiple hats.
Yeah.
Well, and I think that's also, honestly, this is something that I think we've acknowledged, especially for people that are, reading any of the, acts, literature that's coming out in the relation to COVID, is there's also, as leaders in organizations, we also have to try to take care of ourselves in the midst of this shit show.
Mm-hmm.
Because if we're making these critical decisions, and these decisions might be changing on a daily basis, and really it's up to us to decide, like, do we take this risk or we not take this risk? And a consequence of this could be someone dying. I mean, that's some heavy stuff right there.
Mm-hmm.
And so I'm also, and so I also think there's the piece of, like, how do we do this and understand that potentially we'll be engaged in these types of interactions, decision making, and be asked to be engaging in these types of, kind of complex, high level, decision making behaviors for, the relative future. How do we sustain that? Because my concern, frankly, and I'm just going to be really direct. I've been under shelter in place orders, for 2 months. I'm not running an ABA organization anymore, but I'm still a human. And I feel like I'm, like, starting to lose it. You know what I mean? Like, I legitimate, Michelle and I've had this conversation, and Ryan, I'm just like, oh my gosh, I feel like my quality of life has been so drastically reduced. How do I maintain, my sense of well-being to allow myself to, really have the room to make good decisions? And that's even, more intensive when you are, running an organization. So I'd love just to hear from your guys' perspective, like, what are things that you've done and continue to do that you found really helpful to allow you to be able to be in the best place to make these really hard choices and decisions for your organizations?
I don't know what people are doing to for the organizational level. I've, in a way, been working on my own in my house for the last, like, 2.5 years. And part of what I started setting up as much as I could and had to adjust, I guess, during this time was making sure I always planned, like, the family things first. And so for me, that's shifted from just trying to prioritize every week in our group family chat of, like, when are we getting together to FaceTime and say what's up to each other. But for me, it's been, we're all good at that, but I've kind of stepped in that leadership role, I guess, in the sense of, when are we getting together and chatting? I've had a couple people call me this past week. We were texting, and then I was just like, hey, if you want to chat. And I feel like that's one of those things that I should have been doing sooner is I didn't realize, like, I'm good, but there's people in my community that I could be reaching out to and saying, how are you doing? Rather than replying to the text, call them for 5 minutes. I know I talked to Selena once this week and a couple others. And, like, I also really value that time. Even if it's 15 minutes or 20 minutes of a chat, I feel like I'm in that social interaction a little bit more. And then for me personally, it's also been as much as I can, like in Nevada, I've got trails in my backyard. Pretty lucky with those, but, and the governors like to go out, hike and those sort of things. but I make that a priority every day to get out, even if I'm not getting my work done that I need to get done that day. Granted, it's not like life, health, safety of somebody, but there's things I'm not getting done purposely because that's more important. And it's hard to walk away from those, but that health side of it's been huge for me, right? I never walk. I walk every day now.
I know yesterday I got 17,000 steps.
That's
17.
ridiculous.
Yeah.
When you put it on your dog and let him run around, it doesn't count.
What did you say, Stephen?
When you put on your dog and let him run around, it doesn't count.
Well, yeah, I mean, because like, what have I done? Like, I work out every morning. I maintain that routine. I get up at 4:50 a.m. and I work out at 5:30 a.m. and that's just what I do. And I've been doing that for years. And so that's been a really important thing for me. And I agree. I think prioritizing those social pieces, I think kind of trying to piece your day out. And like for today, for example, you know, we're going to have a birthday party for my daughter. So I had some calls this morning. This is my stuff that I'm doing today. I have some stuff that needs to be done. And I'm like, I don't care because my kid's more important. And like, I need to do this to have a balance. I think
part of it is also remembering to home from home. I don't remember who told me this, but like, we're so used to the day-to-day grind of what we're doing in our jobs now at our home. It's like, you got to figure out how to do that home thing. And so I think it's struggling there. And I've always recommended that people kind of share, chat with each other, have an accountability buddy, something like that, where you can start to, whether that's your significant other or someone that you're calling and just saying like, this is what I'm doing. What do you think? But that's been pretty big. On the organizational level, was there anything? Because that was the original question, right?
Yeah, well, yes. But also I always have like, I don't ever post questions that I don't have opinions and suggestions about. People do that, like ask questions and like never contribute to the conversation. I'm like, seriously? I'm tired of answering everything. But I think in the spirit of, you know, constant communication with your staff, et cetera, I would really encourage you guys, for those of you in leadership positions, you know, I think at the beginning, if you are seeing people at the beginning of the day, or if you have Zoom check-ins or meetings, I think it's really nice to just kind of take the first couple minutes and just kind of set the stage and be able to occasion people being able to have kind of like radical transparency with where they're at. Because I think you really need to know from a leadership perspective, like who is like bringing, you know, kind of their A game that day and who isn't. And it's not about shaming people that aren't, but it's about acknowledging that people are being honest and they're telling you where they're at right now. And then maybe distributing tasks that need to be done relative to some type of like rating scale or something that just acknowledges that like this is a really challenging time for everyone. You're not going to be able to function on all cylinders every day. And in behavior analysis especially, I mean, there's a lot of literature already out there in terms of like burnout. This is like the ultimate burnout situation, right? And what I'm scared of is that people are going to run away screaming from our field because they're just like, oh my God, are you kidding me? Like there's all these protocols now and I have to do these mail, you know, so how do we, you know, not only maintain the sanity of everyone that's working in our organizations, but make sure people want to stay here because we know that we already have a demand and supply problem. There's way more demand for our services than there is supply. And so I would just, you know, and maybe you guys already do this, but I just think it's nice to be able to, you know, have a culture and an atmosphere in your organization that really values communication and transparency and allows people to be able to say like, yeah, you know, I'm all here today, or like, gosh, I'm just really struggling. And then you can, you know, react accordingly. It'd be the same thing like with any kid, right? Like if you have a kid that's coming in and there's like a setting event, and maybe they didn't sleep well the day before, or they had something hard happen at home, you might not be putting the highest level of demands on them that day. I think we need to do the same thing for ourselves and for the people that work with us.
So you mentioned that we do a weekly survey, and we've been doing that even before.
We used to do the pulse survey, yeah.
Weekly pulse survey, 30-second survey, and some of the questions on there are things like, are you happy at your job? Like that's your typical, are you happy at your job? And then one of the other questions on there at the end is, you know, were you happy? And I don't know how it's phrased, but something along the lines of, were you happy with your week last week? Like did everything go well last week? And, you know, like a scale 1 to 5. And so, and then we have areas for comments and kudos and feedback. So that way we have our finger on the pulse. We know it's sent out to everybody. We get pretty good response rate for most of our folks. We review it for hours on a weekly basis. but it's our way to really stay in touch. And more important, if someone had a really bad week, it's okay for them to tell us that, and we want them to tell us that. This was a shit week. Everybody canceled on me. People were sick, whatever the case may be. I had personal stuff go on, but you know what? That's why I didn't answer that email fast enough, or I was kind of short with my supervisor. But I'm really happy in still what I do. It just was a really bad week. And so we're, like I said, we're constantly trying to stay in touch that way with everyone within the organization, from, like I said, leadership on down.
Mm-hmm.
We did something similar when I was managing a day program. We had 45 staff, and it was my number one priority, but my hardest one to knock out, which was just like daily check-ins with people, building rapport with them, but also getting that sort of stuff verbally. We did some anonymous stuff as well. And I get that modalities changed, but that was one of the hardest things, I guess, is what I'm acknowledging for me as a leader, to learn how to build up my behavior of doing those sort of things. And it was not a quick return, but that delayed return was amazing as a result of doing that. So 3, 6, 12 months down the road, that's where there was big changes, and not only how our community culture was working there, but also the information that I would voluntarily get from staff totally changed there, of them coming up and saying, hey, I didn't really understand or like this decision that you all mentioned, whereas that would have been this thing that slowly was under somebody's skin for a long time. Right.
Right. And so like our surveys our weekly surveys, obviously they're not anonymous, so we can kind of, stay on top of things. And we encourage responses, even if they're like, I hate Steve so much. Every time he calls me, I freak, and so what would happen is that someone would follow up, it wouldn't be me, and say, tell us what's going on. And so we've been able to solve so many issues preventatively before they boil over, because of the weekly survey.
I feel like that kind of goes hand in hand, like you're sorting out this gray issue area, but that feedback loop helps you kind of know the perception of your staff, how they think you're handling this gray area as you're moving forward, right? It can allow you to make those decisions in the moment.
Yeah, I mean, even just recently, someone said I wasn't getting what I need out of my supervisor. I wasn't getting what I need out of my supervisor, and finally, after the second time reaching out, saying, "Are you asking for someone different?" And we're small-ish company. We don't have a lot of supervisors. They said yes, but I'm not looking to hurt somebody's feelings, and so on and so forth. We said that's not the point. The point is about you getting better and getting the things you do. And so she was able to get switched, and the supervisor that was having, the disconnect got some great coaching and said, yeah, if we could have improved and got somebody else. I mean, everyone was, satisfied with the response on it, and not, I'm dissatisfied with my supervisors, I'm dissatisfied, and then they just leave, and you do an next interview, it's like, why did you leave? It's like, well, I didn't like my supervisor.
Yeah.
Again, it's about, we try and, like I said, we don't catch everything, and things like that happen. People, they put what they want on the survey, and then we have a section for shout outs and kudos, and we put those on our Facebook page. I mean, again, just anything we can do to try and keep motivation. Did
you have something to add there, David? I thought you were.
Yeah, I was. So there was a comment that someone made a while back about that burden of the difficult decisions that leaders make, and it's kind of sitting with me. So one thing that I wanted to throw out there is I think that sometimes, especially as we move up in companies, we feel like we should be competent in the decisions that we're making and what we're doing. There's a lot of good research suggesting that if we can create teams of people that are making decisions, especially when you look at end of life ethical decision making teams, things like that, where you can deal with some heavy stuff on a daily basis, which some behavior analysts now can contact. By having a team of people that make decisions, you can reduce that burden, and actually leads to often more optimal decision making. So I think what's important.
Should be making decisions in a vacuum, David? Is that what you're saying?
Yeah, exactly. So not only, I think, recognizing that we don't have to be competent right now. This is the Wild West. It's okay to create a team of people that we can bounce ideas off of. And by bringing in different stakeholders from different parts of the organizations, we can give people the opportunity to feel like they're being involved in organizational decisions, but also relieve some of that burden, so we don't have to deal with this day in, day out for, the foreseeable future. The fall is going to be interesting. We have flu season that's going to come back. That's going to compound with COVID. It's going to be a ride here for a bit, I think. So
Yeah, no, I agree. I think that is definitely optimal, David. And I think for a lot of organizations, that's how there are leadership teams in place. And I think that there are some of those structures that already exist. I always get concerned about organizations that aren't operating at a larger scale and don't maybe have the resources or the staff to do that. And then, they are making decisions in a vacuum. And I always feel, in behavior analytic organizations are going to be judged by like the least among us, right? Or the smallest among us. And so I'm also wondering, and I think that this webinar is a great example of how do you then come in contact with other people within your community that may not be at your organization, but that can offer you some guidance and perspective. Understanding, to your earlier point, David, that a lot of these decisions are going to be so individualized and very much based on what's happening in the context of your specific organization. So I don't ever want people to like overgeneralize things. And again, like there's not a one size fits all, but I do think that there is a place and should be a place for these types of conversations for people that are like, gosh, I feel like I'm operating alone. Or if people are in organizations where this isn't valued and it's not part of the, the culture. I mean, of course, I always say like, don't work for an asshole. So find a different job potentially, but this is, I think, a more challenging time to do that. I just think to the extent that we can offer these opportunities within our community, and also to show examples of like, how could this, work as a small group, or what are the things that we could tackle? I think that that's important as well. Just because I know that there's a lot of organizations still in behavior analysis where what we're seeing, you guys, and you understand this is, and I think that COVID is just going to exacerbate this. You're seeing this. So there's a consolidation happening. So you have a lot of like big organizations that honestly through COVID, they're just going to get bigger because they have the money to wait this out. They're PE backed, they're huge. They're going to make, a lot of organizational decisions to try to like stop the bleed, but they have the resources to see this through and are going to be the best prepared to be able to have a rapid recovery. And then you have kind of like the smaller groups that might, in the context of COVID, be getting a little smaller right now because that's the only way they're going to survive. And so what you're, losing a lot is that kind of middle. And so when you have more an industry that's looking more as a function of extremes, and this is really akin to, medicine right now. It's like you have like the Kaiser's, United Behavioral Health. I mean, I don't know if you guys realize this, but almost all of our commercial medical care is done through like 4 or 5 companies in the United States. Like that's it. But then you have like your like local, GP, like Dr. Thatcher, who's been providing services in your community for 45 years. And he, was the one that, birthed, your mother, and he was the first one to catch your mom and he caught you too. I mean, but you don't have a lot of that stuff in between. And so I just want to make sure that, the kind of the smaller emerging behavior analysts, smaller groups, still have access to this stuff too, because all of us are going to be judged the same. And so, and I also honestly think that larger companies have an obligation, an ethical, moral obligation to the field to help kind of support these other groups. Because again, people look at our industry just like with a broad lens, and they're not differentiating right now between, the card and the trumpet or the butterfly effects, and like, hey, small provider in Oklahoma that has 1 BCBA and 20 kids.
I think right now collaboration within your community and with other providers in your immediate area is vital for your survival. And I live in Las Vegas. There's very few companies out here, and Ryan visits often, I think, to the Las Vegas Valley and has some connections here, but there's not very many providers. That's one of our biggest things. And for me, I'm always trying to reach out to other directors, other owners, and a lot of the companies out here are the smaller companies. They're BCBA owned, and so they're the ones that are struggling right now. And so we're just trying to help one another and figure out, what do we do as a community? Because our community is not big at all, and so what can we do with each other? What can we share with each other? What resources do we all have that we can share and collaborate to make, to keep you guys around and not lose you guys? Like some of the companies on our Facebook, Nevada providers have said, we don't know if we're going to last because we're bleeding and financially, and we're not getting any revenue in. We're still paying our RBTs and whatnot. And so what's next? How do we move forward from this? So
That's hard.
Yeah.
I don't know if anyone has answers there. But what I love about what you just described, though, is that collaborative process, I think.
mm-hmm.
Yeah.
I think I don't know how to, I think it's super unfortunate, but like I follow some different people who are talking that talk about just larger economics and building businesses. And it's one of those things where we can talk about why it's set up that way and how it's unfortunate for the small business owner. But I think sadly the reality is like we're running into what happens when you build a business in a great economy and that economy goes to shit. And it's like there's no way around that outside of trying to hustle for the PPP. I know that was a complete mess compared to especially for small business owners and what they were expecting. And even like when I was talking with Sarah about this when I was going through like my minor in business. It was one of those things where it was talked about like aim for 6 months of reserves cash to be able to keep going. And I get that is also crazy amounts of cash that people were talking about. That was one of the metrics when I was working at the nonprofit here in Reno that was looked at is how many days could we go if everything shut down. At one point, I know it was like 34 days. And at one point we had it all the way up to over 180 days and it fluctuated, but I don't know how much I feel like there's some hard lessons, unfortunately, and through people coming together, maybe that'll alleviate some of it and sharing ideas and resources. But I think a sad reality is going to be some people just get a complete punch to the gut. And hopefully, as a result, we can kind of come back together a little bit stronger. But like we unfortunately, we can't provide services in a vacuum. And like we're realizing that some of us are more than others. Like the fact that you started up in October, Christine, is like so unfortunate for the situation that's going on, right? It's just like unfortunately, that's the lesson I think some like we're all realizing and learning, and I don't mean that in a bad way. I'm curious what people will do next, right? And like how we'll rebuild this, because there was a lot of fragile people, not at their own fault.
Well, I'd like to share a little bit, like as a parent, first and foremost, and that's why I came into this community, because I have a son who received services and I saw the value. Mm-hmm. And I think, this is really time to come together and collaborate and help one another, because there's going to be enough clients to go around, and we should, put aside the difficulties and come together. And I raised my hand for a bit and then put it down because Christine said it kind of exactly what I was going to say, is that, if you can form a group of, like-minded business owners in ABA in your local area, then, we did that early on. It was funny. I got a call from somebody and I said, we really should put together a small group of people, of owners who can discuss these challenges and help each other solve these problems. And he said, oh, the meeting's in an hour. I was going to invite you to come. Awesome. And it's, a small group, so it's manageable, but answering all of these questions and sharing the resources and walking everyone through it. And it was interesting because a couple of weeks ago we met and I had gotten an email the day before that just said, you've been approved for the PPP. The funds will be in your account within 3 days. I didn't sign anything. I didn't have to, really go through an arduous process. So I was like, this is fake. It's not real. It's not really going to happen. And then somebody else said, yeah, the exact thing happened to me. And within 48 hours, the funds were there. Be ready to figure out how to spend them. And now we're walking through, that process together of how to allocate those funds and how to apply for forgiveness and what that's going to look like and what we need to account for. But without that group of people that I could, access and call, we're a very, very small organization. And I think really been able to build those relationships over time by, walking up to a dinner and saying, hey, Stephen, and getting to know him and talking to him about his business. And luckily he was super nice. And, we had a nice connection and chat, but I think I've just had to not be afraid to do that over time, to build those connections of like-minded people so that when I need help,
I can call Sarah, I can call Steven, I can, talk to people that are going to provide that really good guidance, because we're, like I said, we're really small, and I can't always have a group of like my staff to talk to, because some of these decisions I have to make like for them, and I want to take their consideration, but I can't necessarily talk to employees about it, if that makes sense.
Part of this, I think, is also like how agile and quick is your company, and realizing there might be opportunities to like restructure and reframe that. When we worked at that nonprofit, guiding and turning a ship required oftentimes like board of directors approval in a month. And that's just not something that works right now. And so I know that's one thing that's talked about in business a lot, is just like how quick and agile are you, or do you have a committee or a person that can start to sort through these things when there is uncertainty? I had this weird rule in that nonprofit where every once in a while, it's probably once to 3 times a year, I would get a call on, hey, something crazy is going on. We need data, numbers, crunch. There's a new opportunity. It might be a really good business opportunity, or it might be some unexpected thing where a funding source was held on pause for 3 months or whatever it was. We need to figure out the funds and things like that. Sometimes I would stay up all night crunching those numbers and figuring it out, but it was like that small little way that I could help that company be more agile. It was discussed as this weird extension of my role. So I guess I've been a part of, like, I feel fortunate right now in my business of one that I can move super fast in things that I do right now. And I get that that's not everybody, but we built it into this larger 250 employee organization as well, realizing we needed to kind of adapt and move quickly there. We had, I don't know if we hit on it here, but if anyone has any supervision, like how they're handling supervisees right now, I know Christine was asking for that, if you can share it in the comments. Christine, so have you seen a stronger collaboration down south as a result of all this? Like people are talking and working together more?
Yes and no. I know that we did have a provider call with the Nevada ABA providers page last month about how people were providing services and what they were doing, and protocols and stuff like that. And we all shared and exchanged documents that we all created so that we didn't have to rewrite the wheel every time. That was great. And there's supposed to be another call next week, so we'll see how that pans out. But Vegas is weird, and I don't know why Vegas is weird. I'm originally from California.
Nevada's, I think Nevada in general is also weird. That's not a just South thing. The Nevada, the Reno provider climate is very cliquey, and like we do this, we talk here, we don't talk to so-and-so. And it's partially intentional and like bad blood and things going on, but it's also partially that just people are kind of in their own neck of the woods dealing with their own things too.
Yeah, and I get there's bad blood, but I mean, we're a field of behavioral change. Like, like whether you're in OT, speech, ABA, like we just need to work with each other. Like, at the end of the day, our end goal is for our clients, right? So, and coming from California, especially in LA, where I learned most of my skills and everything, moving to Vegas and coming into this like climate was like, what's going on? Like, why are you guys not talking to so-and-so and this and that? And like, we should work together. Like, there's, like Michelle said, there's enough clients to go around. Like, we all have 6 months to a year waiting list. Like, we can work together and still serve the greater good. Like, we don't need to be, oh, you're a different provider, or you're a director of this provider, I can't talk to you because we have secrets. No, we don't have secrets. We're a science. We all do the same exact thing. So I don't know.
These things can act as a MO, right? And start to alter those sort of things. So I'm on the fence of like hoping that we start to see some more collaboration across different, whatever it is, state organizations, et cetera.
But that also, I mean, but this is, I have very strong feelings about this. This is, for those of us that are in positions of leadership within behavior analysis at state levels, at national levels, it is our job to model this behavior. Like, if we want other people to do this, then this is how we have to live our lives. And that's something that I have tried to do for a very, very long time. When I was in the head of my organization, when I was the president of CalABA, when I was a board member of the Council of Autism Service Providers, I think a lot of these, this kind of like, I have beef with someone, you're a bad person. Some of these are just bad behaviors that are learned in graduate school because this is like petty academic shit. And we don't have time for it right now. We really don't.
No, and we're not in high school, right? It's not high school.
Yeah, and it's just like there's way bigger fish to fry. And I think that behavior analysis, we're in this incredible growth phase, and we're experiencing a lot of growing pains as a result of that. And so this is now the best opportunity to really look at the types of infrastructure that we have at a national and at a state level, to make sure that the types of leaders that we are electing, if that is to our boards of directors, or the people that we are listening to, the resources that we are consulting with, are ones that exemplify and really personify the values that we have as a field. And that kind of goes again back to like ethical conversations of like, who are we? What do we value? And then how do we live those?
Mm-hmm.
And this is, I have been very, very happy with the amount of, and the willingness for people to share information in these last couple months. And again, I said this earlier in this conversation, I very much hope that will not change, because I believe that this is going to be a critical piece for us to continue to elevate the work that we do, to make sure that the recipients of our service obtain the best outcome possible. And also, I just think that, again, this is a value that I have, and I would challenge everyone that's in leadership positions in behavior analysis to act accordingly. Because people watch us, and then they, and I see this all the time, and they imitate what we do. And so if we are, talking smack about people, or like, I can't talk to this person, and then you have people that are under your supervision or work for your organization, then they're getting reinforced by engaging in those behaviors, and then they're carrying it to whatever other workplaces they have, or, whatever organizations they start. And so this is just, we don't have time for this. So let's crowd it out and really, again, show what leadership is all about. And to me, it's coming from an open, collaborative place. And again, understanding, to Michelle's point, like, oh my gosh, there's way more demand for our service than any of us can ever provide. So like, there's no room for not being able to and being willing to work together.
So we have a question that was submitted privately. David's for you. So it says, with what we know now, it was somewhere between maybe 45 to 60 days after your publication that you all worked on. Is there anything that you all would add or modify from that article flowchart?
Yeah, I think so. And I think we talked about this at the last panel that we had, and this kind of speaks back to what we talked about at the very beginning with the observations. So that article was written at the time in response to that acute phase that we were in. And we wrote it as what we thought were recommendations at that time, in knowing that the shelf life was short.
Mm-hmm.
So I think that there are some interesting challenges, and there have been a few papers that have been published after that that I think clarified or highlighted aspects of our model that could have been expanded, like the Colombo article, which was a nice response in Bath, that I think expanded the how to go about telehealth services and navigate that a little bit more. So I think in terms of the modification or the change in the model and the decision-making process would be kind of the conversation we're having today. So initially it was Band-Aid stop. Let's make sure we understand what's going on before we put lives at risk. And now it's more of a long-term maintenance. How do we open up? How do we scale? How do we play around with different sectors? How can we actively plan for a resurgence of cases so we can have agile policy analysis moving forward to mitigate risks all around? And I think that's a very different conversation of decision-making and the decision-making model than we put out 45, 60 days ago.
The other side that I had was kind of on the ethics of this all is, this is a selfish one that I told you I wanted to ask myself. I was chatting with a couple med students that I know. They're finished their third year, going into their fourth. Super smart, knowledgeable. 4 of them. Perspectives were across the board on like, not as big of a deal, and this is a really big effing deal. And part of like the discussion after a little while made me realize that I think what's going on here is that people that say it's not as big of a deal. And this is also just, I guess, a fascination that I have when it comes to politics or whatever. Like, why do people take it super seriously sometimes and other people not? Is that I gleaned, at least from this medical community, is I think that they have like noticed that this is a part, like there's certain diseases or things that go on in the world that are just totally messed up and wreak havoc. And for them, it seemed like the biggest thing was like, oh, this is another one that does this. This is super messed up. But in a sense, like why it wasn't such a big deal to them was because they do understand the stats and data, and they see day to day what's going on with cardiac arrests and other issues, you know, that turn into these big issues. So it's almost like, I don't know, I feel like this is an ethical discussion, but it's also like, this has been a giant perspective taking activity. And I think one of the easiest ways is also to realize, like, anybody that has, like, we're kind of living in this weird way. I don't want to discredit it, but we're living this weird way as if we have like an immune compromised disorder ourselves, right? Like we're treating, like the whole world is realizing what it would be like if you lived under some similar circumstances there. So it's, I guess, an ethical discussion for me on how do you reopen, but it's also like, this has kind of always been here in some regard. And now we've experienced what that feels like a little bit, right? Or how our business may need to shift with that. Does that make sense?
Yeah, there's all sorts of fun stuff that you just brought up there. So I think one is this health literacy piece. So I think as behavior analysts, we're great at reading behavioral data, behavioral literature, and things like that. But we're not necessarily trained to read medical literature, epidemiology, public health stats. And that health literacy piece, I think, has been a challenge. If anybody follows like science communication professionals, it's a whole profession in and of itself. They've been really grappling with how do you make the data that we have digestible to the public. But similarly, when we like talk to parents or caregivers, or we're training staff, if you make it too simple and feel like it's so obvious that anybody can do it, there's also harm in that. So it's this like really interesting balance of communicating what actually is going on, and as a public that's not trained to view those data, how well are we actually reading it and how literate are we, which is a unique just conversation in of itself. The other thing I think that you brought up that's really interesting is we know from the basic literature on choice and decision making that if we look at how different people value different commodities or outcomes, it's going to shift. Like I love apples, you love oranges, whatever. It's all going to shake out. And so you put any of us in the same context, we're all going to choose outcomes differently. We also know that everybody values gains versus losses, or reinforcers versus punishers differently. So that's another added piece on this decision-making puzzle. So we have all these outcomes that are balancing these gains and losses. We also know that what we're talking about are kind of short-term versus long-term gains and benefits of these different outcomes. And that you put any of us in a room with just money or just food, our delay preferences are going to differ. And then you add on top of that uncertainty and risk, which is another dimension of human behavior that we know differs amongst all of us. So you have this crazy complex situation that involves multiple outcomes, all sorts of uncertainty, delayed outcomes, gains and losses. And then on top of that, we also know from the basic literature that I'll respond to just descriptions of events different than events I've actually experienced, which gets again to that healthcare provider versus us now that we're just experiencing this stuff. And so you throw all that together, and what shakes out of that is these different value rankings in this gray box where people are saying, no, the line's here. Someone else says, no, the line's here. And at the end of the day, we have no data to know where that line is. But it helps me at least make sense of why people will get angry at each other and say, no, you place too much emphasis on public health, and someone say, no, you place too much emphasis on family or whatever.
Yeah. And I guess it's like the acknowledgement of that and realization helps me kind of cope with like why I see differing opinions and stuff like that sometimes within our field or outside of it. It also sets me a roadmap, I feel like, on I don't know, if I can start to read and learn a little bit of these other fields and what they have to say, then cool. I get that not everyone has that time, but it kind of tells me like where I can go next. And then I think this is I didn't plan on this, but like to kind of tie it into the stuff that you said that you're doing when you first announced, yourself and the machine learning, this like cool stuff that you're doing is this is where I see behavior analysis, like we'll continue to be this gray area, and we're going to struggle with this stuff as a community until we start to figure out how to collaboratively work with these other areas. So like you talked about how many variables are, how unique this is to every single, you know, all those variables are so unique on where you're at, the organization you're in, blah, blah, blah. Like this is I think a way, and like the way to solve these is through starting to move into the world of like technology and the machine learning stuff that you're doing, you know, like we like, it's going to be great until we can start to tangibly figure out what's going on and put these more into analytics to help us drive these decisions. Like there's just too much for a human. There's too much for a human, right?
Yeah. Computers help. They allow us to manage.
It's scary and they can help, but
yeah. But what I also think is interesting about it is we know behavior adapts through variation and selection, right? So I need to be variable in the perspectives I'm taking, the data I'm considering, the outcomes I'm pursuing. And I think more broadly, we can say, what does machine learning tell me? What does a public health perspective tell me?
okay.
What does the biophysician tell me? What do all these different people tell me? And then we can start watching. We can kind of step back saying, we can see what different people do, the decisions that they make. And then we can start seeing what actually works, right? That variation and selection over time. And so that's where I think that technology computational aspect will provide a really unique perspective that's very helpful in many situations.
Yeah.
And that's another piece of the puzzle.
It's not a call for everyone to go learn machine learning, but
oh no, it is 100%. We need more behavior analysts doing it.
We do. There's a few people. Beth with Opera and Coffee has also started chasing and pursuing that. But if anyone's looking for, like, I've learned from David just this last couple of years on Twitter, kind of following some of the things he retweets and shares, starting to get some of those perspectives of what other people are talking about out there. And it's been useful. So thanks.
Thanks, man.
Yeah, I guess I get really fascinated with this idea of like, this is a giant perspective taking activity that in a way we've always had some very similar risks present all the time that we did not care about. Our field is what I mean, like as a behavior analyst, our industry and other industries. And so it's this weird, like.
Yeah. And another conversation I've always been fascinated with is if you look at like the bioethics literature, the just allocation of scarce resources is a big topic. If I have limited ventilators, who gets them? Like, how do we make that decision? That same kind of balancing resources in this public health versus individual decision-making hasn't really popped up in behavior analysis. I've been searching around, like, where can we find an example of this? But what's unique about COVID is now all of a sudden this conversation's at our doorstep. We have to balance our own interests with the larger public. What does that look like? I don't know. We're all trying to figure it out. There's a bunch of conversations that we're now a part of, like you're saying, that we didn't necessarily have to engage with before.
Was there any other questions or comments? I know we planned to end right about now. We can end on a positive hoorah. Sarah's always good at those. Your caffeine's probably at max.
I like
but
it.
I wanted to make sure there wasn't any other statements that either you wanted to make or people wanted to ask.
No, I mean, I would just end with, I appreciate people being part of this conversation and continuing to engage with each other and to ask hard questions. And I'm really fascinated to see, like what future me and what our field is like in a year from now and 2 years from now. And again, like, I think that this is some precious time that we're being given and having to make some changes in how we view things and the choices that we make in, kind of a really crazy context. But I'm hopeful that we can do the right thing. And again, I've just enjoyed so deeply all the work that David and his colleagues and other behavior analytic colleagues have done in terms of publishing articles, sharing information, and just, again, kind of putting all other things to the side and like, gosh, how do we coalesce as a community? How do we, start to create these like decision-making models, these risk assessments, think about things that we haven't thought about before, to start building up the body of literature, especially as it relates to ethics in our field right now in this context. And so this is great. And despite the fact that I hate staying at home and I hate having to see all you guys on Zoom and not being able to see you in person, I'm really proud of the work that we're doing in the midst of all this, and I'm really thankful for all of you.
Yeah. Write in the comments if you're interested in getting together on this discussion again, like something like this, I guess. That'd be interesting to know. Christine mentioned it. I feel like the thing I don't live the day-to-day of the practice and the organizational side of it right now, but I do get comments, reports, DMs from people of saying like there's this messed up situation going on, or I'm stressed out, or things like that. And one thing I've been telling people back is I hear these from all over the states and outside of the states. Like, people clearly aren't alone. I don't experience that day to day, like, and we're all experiencing it differently, but I know everyone, no matter if you had deep pockets or not, or a savings account, whatever, like, everyone's day and world is shooken up. So I don't know if there's anyone that personally wants to just like reach out and chat. I've been trying to be that person as well. So hit me up if you all want that. Anything, David, closing?
No, you guys both just ended that so nicely. I just wanted to thank you both for putting this on. You know, I think throughout all of this, the resources and the opportunity to have dialogue that you both have created has been welcome.
Well, we'll stay on if anybody wants to ask like more private questions or anything like that. So